好，我这边马上可以啊。哎，你开吧。What's the double park, parallel park?
Just find it easier with this.
好。那个
This one.
你先别吵，别吵，我这边开会啊。别吵，别吵。我再等一下啊。现在27人，再等一些医生上来，我们再开始。那个金梅啊，你可以让那个林医生 share screen 了哈，那我来开始，好吧？
好的。
OK， 各位医生，大家晚上好啊！今天是我们安排一个非常特殊的日子啊，我们请到加拿大的麦克林教授跟我们来分享种植呀。我想哈，我们首先请那个卢勇老师来做一个 introduction， 好不好？把时间交给卢勇老师，然后 林医生跟我们分享。我们非常感谢林医生啊，能够来到我们安博来跟我们在北美的华人牙医一起来分享。好，我们把时间交给陆勇老师。
大家好，我们非常高兴的呢，林医生来跟我们分享那个实际上是跟我们讲座。林医生，我认识林医生10几年了，我就讲我个人的感受哈。林医生是我们加拿大非常有名的种植牙的一个教学者，他不只是加拿大，而且在中国或者是在整个北美，全世界他都是一个很有名的教学者。他的教学的课程从低阶的到高阶的，他的课程有一个 institute 叫 TIDE，我不知道简称哈，等一会林医生跟大家讲一讲。我的种牙本身就是林医生教的，10几年之前的呢，我参加了他的那个课程。一点一点学会了，他是从理论和临床实际当中都是非常优秀的。他是一个非常 talented 的，我自己认为他是一个非常 talented 的一个人。然后呢，他跟我们这个群里面的很多开业医生一样，他最开始的时候是一个 GP， 但是他是一个 super GP， 我们就这样的，这是一个特别的一个 GP， 特别能干的一个 GP。然后呢，后面呢，他又去做的 prosthodontist， 在多伦多大学做的 prosthodontist， 然后一直是多伦多大学 prosthodontic department 的一个instructor， 然后呢，同时他的 private practice 呢也很好，他 private practice 呢主要是做 implant 的 complication 的 management。所以说他这一次的讲题呢，我也选择了呢，他的 complication management 的一个方法来跟我们讲座。我呢觉得呢，林医生的那个呢，不只是一个教授，他更重要的讲给我们的都是他的临床经验，他的临床也做得很好。那么我们现在呢，欢迎林医生给我们做讲座，同时以后大家。林医生实际上是有很多课程的，那么这个以后大家有兴趣，然后再了解，然后呢，我们可以请林医生跟我们做更多的讲座。好，谢谢林医生。
哪一位是林医生？我把 host 给您，我没有找到。
How do you feel, Michelle? Because this is so far away from a normal 5-star restaurant concept. You know what, Stephen? We're at it.
哪一位是林医生？
Not convinced about the cooking.
请大家 mute 一下，很多人没有 mute。哪一位是林医生上来没？林医生是不是还没有上来？
你等一下啊，你再给他打个电话给他。
林医生上来了没有？
我们
林医
到我们那个
生没有
群里的招呼一下啊。
他刚才跟我说他在网上，他在 log in， 但是没看到。
OK， 不着急啊，我们这是。
喂，对，我是的。您是哪位？哦，我发给您了。 您没看到，我再发您一下，我再给您，您要我发在哪里？微信再给您发一下，要不？对，我
只有
发给
email
您了，email 我也发给，我都发给您了，我2个都发给您了。我
这个
那我再发您一遍，我是发给您微信了，是肯定发了 ，email 也肯定发了。您看一下微信好吗？您看一下微信。
你这么的，那个你告诉林医生，那个 Zoom ID 是505-837-5347。
我已经发给他了。刚才那个打电话的不是林医生，对不起，我没有。林医生上来了没？还没有，我再问一下他。
好，开始了。Hello，
嗨，你好。
林医生你好，我们刚刚介绍完您 ，OK 呀，等你上来。那好，您可以开始了。
已经可以开始那么早？
对，那个要不那个卢老师再介绍一遍，跟着林医生在这儿。
OK， Hi Young Lu。
我来讲哈，林医生，我再介绍一遍哈。林医生呢，实际上是我的 personal 的种牙的 professional 的 mentor，是我的导师。我的种牙的东西呢，是林医生那里学的。10几年之前，我首先参加了他的课，然后呢，他呢一点点的教了我。然后呢，林医生现在呢，或者是这几年了，这20年了吧，将近，他有一个 TED 的这个教学，教学的一个这个 TED 的这个教学的一个 facility。然后呢，他在加拿大、美国和中国世界上很多地方呢，他都做教学。他是一个教授，但是呢，更多的呢是他有临床经验的。也就是说，有些时候我们不喜欢听他的临床的教学，但是不喜欢听其他的教授的课，但是林医生的课非常棒，非常棒。我记得我当时学的时候，一点一点在开始学的时候，我都是受益匪浅。那么林医生的背景呢，他其实跟我们大家一样，他是 GP 最开始的时候，然后他是一个 super GP。他是什么东西都做得好的一个非常 talented 的 person。那么后面的呢，他又做了 prosthodontist。那么多伦多大学的 prosthodontist 呢，他不但有 prosthodontic 的background， 还有呢 periodontal 和 oral surgeon 的这个 background， 所以说他的知识和他的经验都比较全面。 那么，我们欢迎林医生呢，好好的呢给我们呢讲解一下，然后呢，我们能够以后呢，大家有兴趣还可以参加他其他的学习。我们也希望林医生以后呢，能够更多的给我们讲课。好，谢谢林医生。
好，谢谢杨刘那么最好今天晚上我可以用英语去做我们的 presentation， 但是随时如果你们有什么问题可以过于我尽量可以跟你沟通这样子So Dr. Yang Lu was like he said was one of the participants in our program many years ago, and when we run courses we can tell who's going to be very successful, and he was one of very good students. He listens very well, he's got very good hands, and his practice when he was doing the live patient surgeries, he's very diligent, very careful, and I knew that he would be one of the very good students. So again, I'm happy and honored to have this opportunity to present for tonight. So tonight, we're going to be talking about complications in implant dentistry, but specifically, we're going to address and talk about implant surgical complications. So first, again, I want to thank you all for this kind invitation and this the sacrifice to spend time to listen to this webinar, whether you're listening to it live or maybe it's recorded and to be used later on. But nevertheless, it requires us to be spending some time, energy, and effort away from the family and a dedication to the profession to listen to this presentation. So as such, I want to make sure our time together is meaningful and useful, and more importantly, that the information that we're presenting tonight that would be helpful to your own practices and within for your patient base. That's the most important criteria. So anything I'm presenting tonight, and if there's anything that you need or want and I can further support, I want to make sure I make everything available to you. So I don't want to waste the time tonight on my biography. Everybody can read it on their own. But I think what is unique is, like Dr. Yang Lu has indicated, that I was a GP for 13 years doing this type of implant dentistry before I went to the specialty school. And after, as a specialist in prosthodontics, I became a half-time professor, assistant professor. So there's an academic side of me, looking at research, looking at literature review, and looking at the scientific foundation for what we want to teach. And of course, I'm still seeing patients every day. So, when I'm giving presentations, I'm wearing three positions, if you will. One is dealing with the clinical aspect. Second is dealing with the business aspect. At the end, this is still a business. And third, very importantly, when we're dealing with implant dentistry, is dealing with risk management, to make sure our procedures are as predictable, successful as possible, because patients are sometimes not so forgiving, and they have high expectations for success rate and survival rates of our dentistry, now especially with implant dentistry. So this is my particular practice at 88 Finch East, which is North York, Ontario, here in Toronto, Canada. And this is my surgical suite. And I do sometimes provide sedation with an anesthesiologist. So we do have a bigger room for our surgical suite. And anytime we're doing surgeries, we're using two assistants. One's going to be draped and gowned within the chair side. The other one is a runner. And so this is kind of when we're doing our implant grafting and surgeries, this is kind of the protocol. So whenever I'm giving presentations, I think the most important aspect is training the brain to understand what we're doing, why we're doing it, when should we do it, and what are the alternatives of what we're trained to do. What are the other options? And we have to be open-minded, because not every patient and not every site and every case should be managed the same. So having a broad understanding of all the different concepts and different treatment modality is always going to be helpful in dealing with some of these cases. There are many actually textbooks out there. It's already in publication. dealing specifically with implant complications. One of my mentors, Dr. Carl Misch and Randy Resnick, wrote this book, and I think it's a very good book in the sense that it covers a broad range of all implant complications that can happen in implantology. And tonight we're focusing on the surgical aspect, but there are other treatment planning issues, maintenance issues for sure, prosthetic complications and issues dealing with implants. So I would suggest that the members should make an investment in looking at, purchasing a good quality textbook, whether it be hard copy or soft copy, so they can make easy reference to dealing with some of these issues. So this is a good reference. There are numerous articles that are out there, but I think the articles need some vetting and screening to determine the quality and validity of some of the articles. But Misch and their institute, their textbooks, there are numerous textbooks out there. This, among other ones, are pretty good. So this is a good baseline for our participants to have. So make a good investment. It's $200-300. I don't know how much, but certainly it's a good read. Lots of pictures, lots of clinical cases. So use that as a baseline reference. When we're dealing with implant complications, it could be biological, which is usually surgery, hard and soft tissues, peri-implant bone. It could be mechanical, which is a technical prosthetic concern. It could be something measurable, something like, how many millimeters of probing depths and bleeding on probing. So something we can measure, or it could be subjective. The patient says, oh, this doesn't feel good, doesn't feel right, the bite is off. So we don't really know what the patient referencing. We're having to trust that they're giving us an assessment or clinical assessment, and we try to evaluate what's the cause of these problems. Complications could be early, meaning before you even load the implant, such as in some of the surgical issues. It can be late, post-loading, if you will, of the final prosthetics, or it could be during the maintenance phase, years down the road, 5 years, 10 years, 20 years, and all of a sudden they come back and there's a complication and some infection or some peri-implant bone loss. So again, it can be evaluated in the treatment planning phase, surgical prosthetics, and the different level complexity. Could be minor, screw access hole came off, we just fill that in. It could be something moderate, we're losing some peri-implant bone loss. So do we try to retreat it? Do we clean it? Do we want to monitor it, or do we take it out? It could be reversible or irreversible. So we hit the nerve, inferior nerve, causing iatrogenic damage and paresthesia, certainly not a great thing. And it's a potentially, problem. Even you back the implant out and the patient's numb for, a long period of time, that's never a good outcome, and the potential legal ramifications. So with every classification, different people talk about differently. I have an 8-hour presentation on implant complications, and this is the roadmap, which is host and patient related, something dealing with the patient's systemic conditions, bone necrosis, bisphosphonate-induced bone. Is the patient a smoker? Is a patient a diabetic that's not under control, immune compromised? You have psychological status, which is despite what we do, the best we do, and we know we did the best we can to replace and restore the patient's natural dentition, the patient psychologically is not able to accept it. And, unfortunately, we've all experienced that. We do something, we think it's really, really good, and the patient just comes back and always complaining about something, and they can't accept the fact that these are man-made synthetic, replacement of body parts. And then, of course, patient host-mediated responses such as smokers and patients with past periodontal disease. Lots of good literature to show these patients are at higher risk with risk factors of implant survival, implant success rates. Then we can break it down into doctor-mediated issues, which is fundamentally something's off with the treatment planning right from the get-go. So the dentist made a plan and it's already been compromised or flawed. It could be in the surgical, which is what we want to focus on tonight and in the brief time that we have. And then, of course, in the prosthetic phase, there could be a lot of issues and complications. Then we also talk about factors that are more localized, and it could be, interocclusal restorative space, available bone, the grafting, could be hard and soft tissue grafting, which again in itself is an 8-hour presentation on the grafting protocols and complications associated with that, sinus grafting, indirect sinuses, and so on. And then again, finally, in the maintenance phase, the patient completed for a short period of time, meaning in a few years, the patient comes back for recalls, everything's very stable, very good. And all of a sudden down the road, it's hard to say when, maybe the patient's medical status have changed, maybe their dexterity for oral hygiene is not so great, or their compliance is not so great. And now in the maintenance phase, years down in function, there are complications. So again, the complications can be very, very broad spectrum, but this is just a quick overview of the different classifications we can put them in. Again, when we're dealing with complications in my specialty office now, I'm going to say about 50% of the patients coming in have a complication, which is defined as somebody else have done something. It could be around the whole world, anywhere in the world, and of course local, and of course my own patients, they come back and there's a complication. They complain of something, then we very importantly have to try our best to evaluate what's the cause of it, it's the etiology, what potentially caused the implant to have problems, and of course, what are the treatment solutions or management options to replace, the implant and or manage it so that we can keep it in good function. So at the end of the day, most of us know this term called evidence-based dentistry in medicine. Medicine uses it. So essentially, it's a conscientious, explicit use of the best scientific evidence, and we make decisions to that individual patient and individual case. The components is that we want to hear the patient. Hey, what brings you to the office? What are your treatment goals? What happened in your past history with dentistry? Why are you, seeking treatment? What led to this problem, especially with implant dentistry? That means they have teeth extracted and so on and so forth. Then based on your opinion, our expertise, and our training, we would have an input on what we want to provide as a treatment plan. And then finally, scientific evidence, which is what is available in the literature to support our final decisions. Based on these three components, we would come up with a treatment plan. So when we're dealing with implant treatment planning, the first very important issue is the improper surgical implant placement. So surgery might went well, infection may be taken care of or prevented, but at the end of the day, when the implant is integrated to the hard and soft tissues, but it's not in the proper position, that gives restorative dentists like yourself and myself a very, very big challenge and headache, because now right from the get-go, the foundation of the surgery has been compromised, aside from biomechanical issues and stuff. So, early on, the success criteria as drawn out in consensus reports by all the specialists, we're talking about in the 80s and 90s, very, very early on. The first thing they already said, in order to determine an implant successful, the implant should be in a 3-dimensional position to support the final prosthesis, so that when you and I restore, reestablishes function, aesthetics, contour, comfort, and so on and so forth. And there are, of course, other issues. There's no pain, no movement, no minimal to no bone remodeling or bone loss during the maintenance phase. So again, we already know some of the criteria right from the get-go in the 80s and 90s when we first started this. So when we're treatment planning for our patients, we always have to, every time, all the time, think about what is our restorative plan, and it's supported by a surgical component, and really not the other way around, where surgery gets done first, and then we have to figure out where the teeth are going to go. So in the 80s and 90s, when we first started implant dentistry, we really didn't know what integration was about, osseointegration. So a lot of the oral surgeons and periodontists put the implant where the bone is, and they bounce it off to the restorative dentist and the prosthodontist and the lab and say, go and try to fix this. And again, that is, not a prudent way to do implant surgeries. In the 80s and 90s, you have to remember, most of the implants were on the mandibular arch to replace a mandibular complete denture, which is very, very compromised in terms of retention, stability, and support. And when these patients jump from a denture, removable denture, to fixtures that lock in, and even if the teeth doesn't look great, the fact that they can stay in and bite, chew, and be comfortable, the patient will accept that. Today, that is not going to be the standard. Today's standards are very, very different. Just like if I got a phone from a portable phone for you, what we were using in the 80s, and today's standard, you would never accept that because they're very big, very clunky, battery doesn't last that long, and so on and so forth. So standards have obviously changed with time, and today, patients are very demanding. As a restorative dentist, we need to know where exactly the final crown is going to go before surgery started. And we usually use a team approach. You work with different specialists or the lab or the implant company, and we have a very serious responsibility as a restorative dentist to get the implant positioned right so that the final restoration is within a restorable condition. At the end of the day, with implant dentistry, patients want the benefits of the adequate emergence profile, biomechanical loading, chewing function, aesthetics, and phonetics. And we need to know that final restoration will provide these benefits, provided the implants are in the right place with good adequate emergence through the soft tissues and bone. And of course, backing up, if there are hard and soft tissue defects, we need to augment or grow the bone and soft tissues to be in a stable foundation before the implant can go in. So at the end, we're gonna look at the patient's treatment goal and desire. We're gonna get diagnostic records. It could be models, photos, cone beams, wax setups, charting, and we're gonna look at the implant recipient site, soft tissue considerations, aesthetic considerations, and we're gonna somehow get that surgical implant placed in a position that's suitable. Then and only then, the final restoration should be straightforward and should not give us any challenges or compromise end results. And of course, we want to maintain this during the maintenance phase. So the goals of the implant surgery is very important to get that implant in a restorable position when we're doing implant surgery. We certainly want to be atraumatic to the bone, so we don't burn the bone or pressure the bone with pressure necrosis. And we want to make sure we lock that implant in with initial fixation so that we have good primary stability, usually insertion torque of greater than 35 Newton centimeters, or if you use an implant stability quotient like an Austell or Penguin unit, should be at least 60 or higher, because that locking the implant in will prevent what we'll call micro movement or loading to the implants and stuff. And oh, by the way, all the slides for tonight, I'm going to make it available to all your members, so you don't have to, take notes or whatever. I want to make sure we'll convert this to a PDF file, and I'll forward it to Dr. Yang Lu or to your president, Dr. Zhang, and make sure you guys have this available to you so that you can review it on your own. So I'm going through a lot of material. Some of it is very detailed. I don't want you to be concerned that you're not going to have this. So kind of sit back, enjoy, relax, and take in the information. I will make sure that all the slides will be available to all the members. So when everything is said and done, we want adequate bone around the implant, like 2 to 3 millimeters on the buccal and lingual. We want to make sure there's ideal distance from the adjacent tooth or another implant. And we want the adequate length so that we have long survival rates. And of course, we have to pay attention to all these anatomical variations on different zones of the mouth, anterior, posterior, maxillary, mandibular. There are certain anatomy that's very specific that we have to be very cautious with at the end. In the premaxillary area, you know, there used to be a thought to the buccal plate that the implant diameter, all you need is about 1.5 to 2 millimeters. So in the beginning, we thought that would be adequate. Subsequent results and research have shown that is actually not enough. And in an optimal scenario, we want 3 millimeters buccal to this implant bone and good soft tissue profile biotype. And we have studies to show that's what will give us long-term survival and success rates. So to achieve the 3 millimeters, we either have to augment with GBR or block grafts or ridge splitting or ridge expansion, or we have to be very careful in the diameter of the implant we're going to choose. And of course, the positioning of the implant. This particular is showing going through the incisal edge, more like a screw cement retain. And a lot of us are using screw retain mechanisms, of which now this implant should be more palatal behind the incisal edge or coming out of the cingulum. And we want to make sure we respect our distance to the adjacent roots. We're not too close. 1.5 is a minimum, ideally 2. And if you have 2 implants next to each other, would be 3 millimeters each. There are lots of examples out there of the implants being placed without any prosthetics in mind. This is an example, like how are we going to restore this? More, you know, the labs have these nightmare headaches in cases that implants are done. They pour a master model, and now the lab technician is saying, what happened here during the surgery, and how am I going to restore this? In the anterior zones, a lot of these cases in my practice comes through with complications with aesthetic issues and compromises. And so lots of these cases unfortunately happen still, and there's no real reason why surgically someone placed these implants into these positions. So these are all the cases that come to my office, and now we're scratching our head as to say how we're going to fix these problems. Of course, there are also anatomical considerations which we got to get into, but you can see from some of these post-operative cone beams that 3-dimensionally these implants are outside the bony housing and really just violated a lot of anatomy. Another aesthetic nightmare, you know, these implants are very aggressive, and so that somebody's inexperienced end up blowing out the buccal plate, and it's integrated, but certainly there are some serious compromises, and they went ahead and restored it. The lab did what they could with a customized abutment and screw retain. Certainly, we can all appreciate this is not a very desirable final prosthetic outcome. Implant 2 lingual violating the tongue space. You know, in this particular scenario, spacing is tight. So someone decides to put one implant right down the middle, which is very difficult. Like, how are you going to restore this particular case? These are premolars and stuff. So we end up customizing a germinated tooth, if you will, and then trying our best to reestablish function and aesthetics. Certainly not ideal because the implant is already in place, but certainly if it's 2 premolars missing, we would consider 2 premolars. But something like this is somewhat of an acceptable compromise. But certainly in the planning phase, they were the periodontists who did this, they just said, well, that's where the bone is, and the patient can only afford 1 implant. So I put it in the middle because that's where the bone is. And then they bounce it to the prosthodontist and say, help me restore this case. Lots of these examples are out there. You know, this particular patient had a sinus graft, had 3 implants. And now when the patient bites down in MIP, there's no interocclusal restorative space. So somebody should have thought about this way in advance before it gets this far into the case. This is self-explanatory. These cases are just not optimal. Very, very deep implants in the symphysis of the bone, hard to maintain, hard to cement. Lots of these cases are problematic. These 2 implants are very close together, and so restorability is a concern. And lab tries to be creative and kind of, you know, restore for us, but certainly biomechanic, aesthetics, oral hygiene, emergence, a lot of issues, and these things are just gonna come back and haunt us one of these days. 3 implants in the premaxilla, and it's in the buccal vestibule. So I'm not sure how you're gonna restore this. and the soft tissue is in mucosal soft tissue, certainly less than ideal. So real serious problems here. This particular patient have this implant done, and yeah, it's okay. Like, I mean, it's not perfect, but certainly the patient thinks there's a problem because of the black triangle with a high smile line. So aesthetically, it's a real challenge also here on aesthetic issues. So we can see that unfortunately these things are still happening where surgery is done, the prosthetics hasn't been addressed, and now there's a consequence or outcome that's certainly less than ideal for us to deal with these cases, because now you and I have to restore something and know that there's a lifelong compromise in the patient's mouth. So in order to kind of facilitate the accurate implant placement, option one is to use no guides, and we freehand using the adjacent anatomy. Sometimes we go short and with a guide pin, and we use a lindemann burr to refine our osteotomy. Knowing the adjacent anatomy, we would do that. For somebody who's more experienced, a lot of times single tooth, we would just go ahead and do that. We'll get very good results. If you're not confident, we can always get a diagnostic wax set up with a traditional lab fabricated stent or a guide. And now we also have something called guided surgery with CBCT and software planning. And then finally, dynamic guides, which means we calibrate our burrs and our drills and our implant to a camera. And so when we drill into the osteotomy, it gives us immediate live feedback of how deep and our angulation and position of our drills and burrs. So that's what we call dynamic guided surgery. So I made this summary chart to kind of address what is it, the pros and cons of each one. Brain guide or no guide, if you will, is obviously free. You got to look at the buccolingual, mesial distal and angulation, knowing your adjacent anatomy. And again, we will start our pilot osteotomy and using a guide pin and refine with lindemann burr before implant placement. A traditional lab guide will cost us some money, $100, $150, $120. But all it does is start us with a pilot osteotomy that helps with our mesial distal buccolingual. It doesn't really help with angulation. It doesn't help with depth. And certainly when you widen the osteotomy, you're gonna have to, again, use freehand. So this traditional lap guide just starts us into the right vicinity of the area, but we gotta pay attention still when we enlarge the osteotomy. Guided surgery costs a little bit more money. Each lab will charge between $350 to $400, and every additional osteotomy sleeve will cost extra money. But the benefit is that we can have everything addressed in terms of mesial distal buccolingual angulation and depth of the implant. So if you say this, why wouldn't we always do guided surgery? Well, there are two real issues. Number one, is there enough interocclusal restorative space? Because it adds 10 millimeters with the guide and the sleeves and the keys to place the implant. So in the premaxillary anterior zone, certainly you have enough room, but in the posterior zones, you're going to be challenged if you have enough room to go into the back of the mouth to do guided surgery. Second issue is whether or not you need to graft or not graft. So in guided surgery, we want to make sure that the hard and soft tissues are in the right place. There's enough adequate volume. The traditional concept of using guided surgery is that we will not need to graft, or usually we do a tissue punch. So that's the traditional concept with guided surgery. However, as a deviation of this, there's nothing wrong with planning everything on a cone beam, knowing the position of the implant, knowing you might need to still do a GBR, knowing that you're going to open up a flap in preparation for a guided bone regeneration, and still use the guided concept to aid and help us to get the implant into the exact position as you plan it on the software. Then secondarily, you can still graft and get primary closure. So in some of our courses, we will do that. And again, the point of this guided surgery is so that we're very, very accurate with our implant positioning despite the fact that we may or may not need to graft the hard and soft tissues. Finally, dynamic guided, some of these units are out there in technology. They're going to cost a bit more, between $30,000, $40,000, $50,000. And what that does is, again, when you calibrate your burr, every time before you drill into the patient's mouth, there's a camera that would calibrate it and correlates to what you see. So when you drill into it, you're looking at a monitor, you're not looking in the patient's mouth, and the monitor tells you where your burr is going. The angulation and position and the depth is almost like playing video games. So you guys have to get used to this kind of concept to visualize it. So again, we want to make sure that this the surgical guide helps us. So when we're going to doing our surgeries, we have to pay attention to these concepts of where we want to put the implants so that it's restorable. Biomechanically, this is a treatment planning concept. Just very quickly, the diameter length of the implant is a bone to implant interface that takes the stress upon occlusal loading, or the force. And we want to make sure that the diameter, length, and number of implants will facilitate this biomechanical loading and forces. So we need to have enough surface area. Again, it's out of the scope of tonight's presentation, but occlusion, very, very important. Not only because I'm a prosthodontist, but biomechanically, if the patient's occlusion is not in a stable harmony, there will be compromises. You can see teeth that have wear, attrition, and fraction lesions, or breakage and fractures. You certainly see that on our dentistry. They can fracture and break the biomechanical material, porcelain or zirconia. They can fracture the screw. They can cause even fracture the body of the implant. So, or if they have parafunctional habits, these are all concerns. So back to the surgical complications. We have hemorrhage-related issues. We have neurosensory disturbance. We have mandibular fractures. We have issues of devitalizing, or your implant misangulating, hitting an adjacent root. You can violate some very, very serious arteries that can be life-threatening, and which we've seen case reports. Introduction of air emboli, violation of the nerve, and of course, small parts and components could be aspirated or swallowed by the patients. So the best way to deal with complications is to never have one, which means we very carefully select our patients in terms of risk assessment. We do what we call pre-surgical checklists. So just like you and I, before we get on a plane, we have a pilot and co-pilot that would go through a very systematic checklist of everything before they take off. Because once you're in the air, if you discover a problem, just like we already started our treatment, we're in the air. Once you discover a problem, you're not, at a good position, and you have to manage what you have. So what we want to do is, before we take off and before we start procedures, we do a pre-surgical checklist, and during the intraoperative procedure, there's a surgical checklist, and more importantly, post-surgery, post-healing, there's also a checklist. And we go by these checklists and we don't miss anything. That for sure will help us decrease the incidence of complications and or failures. If you're practicing in Ontario here, we have a very strict kind of guideline that tells us some of the checklist issues and some of these cases. And, if you're not in Ontario, you can always still get access to this information, which is very, very helpful in terms of this consideration. And during post-surgical checklist, we want to make sure that the patient heals well, and this is the mandated checklist that they would hope that we would utilize. So the sequence of appointments is that you meet the patient, you consult with them, you and I will decide what diagnostic records we come up with in the diagnosis and treatment plan. We'll present it to present the case, and then get the patient's consent, talk about risks, benefits, and treatment alternatives. Financials too, and the patient says, okay, I'm ready to do this. then this is where the pre-surgical appointment is very important. You and I will go ahead and start the surgery or grafting or what have you, confirm the implants integrated for 5-6 months, what have you. Then we'll go to the final impressions, fabricate the final prosthesis, and maintain it. So I just want to quickly go through this pre-surgical checklist. Very important is, again, the patient's medical status. We want to screen the patient for any risk factors that may compromise their success rates. And we want to make sure there's a clear differentiation between an absolute contraindication or relative contraindication or risk factors, because these patients will not heal well. And we all should know what these lists are. What are the absolute contraindications to implant surgery and some of the hard and soft tissue grafting? We should all be aware of what the risk factors are. And whenever we see these patients, we have to let them know their success rate and survival rate will go down, and whether or not we really want to do implant surgical related procedures, or do we resort to conventional prosthetic solutions such as crown and bridge or removable prosthesis. So you and I should be very clear before we do any of the surgical procedures, especially implants and grafting, what is the ASA classification for our patients? And you should know and confirm this with the medical doctors to make sure we know they're in ASA 1 or 2 that we can manage these patients. ASA 3 and beyond, we got to be very careful if we want to render these types of surgical treatments. We want to confirm any medical allergies, because it can, compound the problems when we give them antibiotics and painkillers or even steroids that gives them a reaction. We want to evaluate during the surgical procedure, is that local only? Majority of the cases they can handle, or do we need to add oral sedation, nitrous sedation, and in some cases, even IV sedation? So again, we have to be mindful that if we use any sedation modalities, even local alone, what dosage, what vasoconstrictors, the duration of action, and how many carpiols as limits we have to use. Same thing with oral sedatives, or nitrous, and of course with intravenous sedation, we have to be mindful of monitoring the patients and things like that. So I hire anesthesiologists, a dental anesthesiologist. I myself used to do a one-drug intravenous sedation, but with the help of a dental anesthesiologist, they put them into a deeper sedation, and it's a lot more convenient when we're dealing with more of the lengthier full mouth implants and grafting and stuff like that. Pre-op antibiotics will prevent a lot of infection incidents. Pre-op analgesics, some studies have shown, will keep the patient very comfortable, and steroids to prevent a lot of swelling and considerations. So there's a lot of literature out there that talks about infection around implant surgeries and stuff like that. But again, infection is an enemy of what we do surgically anywhere in the body, let alone the mouth, which is a pretty hostile environment with a lot of bacteria, a lot of contamination, a lot of biomechanical forces, and so on and so forth. So it's a hostile environment, and we got to do everything we can to minimize and prevent an infection. And again, we would have a infection prophylaxis kind of protocol to minimize the incidence of these issues, starting with pre-op antibiotics. And there's pros and cons to giving antibiotics, but we have good studies from Marco Esposito meta-analysis that says there is a benefit. So we would give those drugs accordingly, analgesics, and again with steroids. So I don't want to bore you with pharmacology on a Friday night. You guys can review this on your own. And then on the pre-surgical workup, we want to deal with implant consents. This is the risk management aspect. Did we give it by verbal, document, or video? We want to make sure the patient is fully consenting to treatment in terms of risks, benefits, and treatment alternatives. We also want to talk about grafting options. Again, there are different materials you can use. Patient's own bone, human donated bone, an animal product, a synthetic product, And now there's also patient blood source, PRF, PRGF, rich fibrin, platelet growth factors can be added to mix in your graft material. All these needs to be discussed. Some patients are okay. They say, do whatever you want to do. Some patients, due to religious and cultural reasons, will not allow you to put people's donated hip bone in their jaw. And some patients will not allow you to use xenografts, cow, pig, or horse sources. And they say, no, you can't put cow product, it's sacred, or you can't put certain materials in my body. So we have to disclose what are the different graft material of choice and make sure we did get a consent from the patient on this topic. We already talked about the guides. And again, you and I have to make a decision when the time for surgery, what kind of guide is going to be used to help us get that implant into a very accurate position. So make a decision on that. Implant system, everybody is going to pick their own for their own reasons. There's no rhyme and reason. There's not like one implant that costs more will work better and one that costs less will have a higher failure rate. There's no studies to correlate that. I think everything works very, very well. More importantly is who's doing the surgery and how they're doing it. That's more important to the point. You want to make sure before the surgery, you already have your inventory ready. Cover, screws, healing abutments, graft material, whatever membranes you need. And of course, very importantly, deal with the money in advance before the patient's to the surgery. And then you can go ahead and book the surgical appointment. Some final items that I've learned over time is that during the pre-surgical workup, we still want to address other issues with the patients accordingly. Sorry, I'm just gonna. So we want to address the healing process, how much time it's going to take. We want to address the post-operative home care. How long, what kind of diet should the patient do? What kind of temporaries, if any, needs to be addressed, and approximate time to completion. So during the surgical evaluation, during the pre-surgical evaluation, we want to make sure that all this has been addressed to the patients. And of course, who's going to restore these cases down the road after healing and stuff. One of the biggest issues, and I think all of us are aware of it, is a neurosensory disturbance. According to the literature, it can be up to 7%, where there's a neurosensory disturbance. The patient say, oh, I'm numb, or the patient said it doesn't feel the same, or the patient says there's tingling and stuff. None of us wants that for our patients, but we have enough incidents to document the literature. So we got to be very careful, because once the patient's neurosensory has been disturbed, they don't heal quite the same. And of course, there could be legal actions and construed as iatrogenic damage. So the literature shows the number, the size of the area during the first stage surgery. What are the symptoms? Does it resolve? There's lots of different scenarios out there, even to the regular surgical procedures. There's these incidents that's out there reported, even third molar extractions can be up to 5% of this problem. Well, you and I obviously want to prevent this and never have it happen. So again, careful planning. Now with cone beams available, people can say, why did you not use a cone beam? Why did you not use guided surgery? There's a lot of technology out there that can help us with the planning. Know your surgical area, know your surgical limitations, use the cone beams and use the surgical template and guide. Now we have cone beam that gives us 3-dimensional positioning. We could draw in a nerve. We can be very accurate with our measurements, and we just want to, respect this anatomy and the lingual concavity and stuff. And so this is a software planning to those positions. If we're not sure, or you're doing a freehand, we can put a guide pin in and burr. We can confirm, stay short and stay away. And before we enlarge our osteotomy or go deeper with our osteotomy, we want to confirm these positions with guide pins we can refine with the Lindemann burr or some kind of burr so that we respect this anatomy and stay away from vital structures. So if and when, which is a bad scenario, if there is a disturbance in the neurosensory area, we can talk about using steroids, flushing into that area and giving post-op steroids by mouth or by into the intraoral environment. But again, you know, this is palliative, and hopefully the damage is reversible. And again, we want to make sure that prevention is the name of the game. And again, addressing the cause and the etiology is very important. There's some suggestion that steroids would help, but it's hard to say because it depends on what the real violation is and how reversible or irreversible the damage may be out there. So again, we have enough technology out there that we should know that before we start our surgical procedure, that we know our anatomy and stay away from it. Another issue is, of course, devitalization of adjacent teeth. Infection is always a problem. Poor surgical technique, and we already talked about different classifications and failures in the literature. So some people talk about mechanical failure. Some people talk about is it late, is it early? You know, in some cases, it's a local environment. You can see there's not enough bone on the buccal plate of this area. So now it needs augmentation. It could due to biomechanical loading. These are mini implants, 2 in the front. The patient came in, everything was hurting. And sure enough, the implants lost its osseointegration, was overloaded, and these mini implants didn't quite well work. I already showed the slide. We used to think 2 millimeters of buccal plate is enough, and I already addressed that. Now moving forward in the pre-maxillary area, we should have at least 3 millimeters of bone to evaluate this. During the osteotomy evaluation, during the actual surgery of the implant placement, the inadequate quality and quantity of bone can be a problem. Surgical operator experience certainly will help. You know, the more experienced you are, the less chance of a problem. Overheating or overcompressing of the bone certainly is an issue. Having an infected site contaminate before, during, or after the procedure certainly will compromise the success rate, or early soft tissue opening, especially during grafting procedures, are problematic. Some of the older literature, you can see the top 3 categories all dealing with a maxillary arch treatment because of the bone density being a concern, that it's overloading and or the bone cannot handle the biomechanical loading. So these are some of the literature, early literature, that talks about when the implants are failing, which sites are failing more than the others, as a comparison through the literature, and also the timing. When are they losing some of these implants? Is that early or is that late and post-loading? And here you can see it's almost like a 50-50 split. So, you know, it depends on the case and the site of interest. This is kind of a late loading. So this patient had a bar overdenture, 5 years, everything was fine. And then all of a sudden, one site, one implant got infected. And you can see we had to find the bone. We had almost 80-90% bone loss. And you can see, unfortunately, it's quite traumatic to remove that core of the bone. And, you know, we modified the bar and we grafted the site, and then the patient have a 3-unit bar overdenture and you know, moved on ahead. And we did not see the need to graft into the, you know, to re-implant another implant because we modified the bar. Certainly not a great outcome, but this is just to demonstrate a late failure that can happen. There could be mechanical issues. We talked about lots of mechanical issues, lots of different classification. Again, it's a separate lecture altogether on dealing with prosthetics or mechanical implant complications. They all have different various reasons and compromises. And of course, to prevent and or to manage these cases could be a consideration. So iatrogenic certainly is out there. That means clinicians are causing some of these problems. Here you can see there's a case, looks pretty good with this guy pin or this burr, but when you take a PA or finish, you can see, you know, despite the angulation of the x-rays could be deviation, you can see this implant is very close, if not into the adjacent roots, which can devitalize the vitality of that root. You know, so do you take that implant out? Do you monitor? Do you prophylactically do the endo? There are a lot of questions that needs to be addressed. I can say, if I see this case coming into my office, kind of the first thing I would request is a cone beam to really confirm the three-dimensional position. Is this a superimposition of a root of the implant to the root, or really is that violating and really banging into the root? So those are all the concerns, because if you violate that periodontal ligament, there's a high chance that root will become devitalized and a potential problem. So we got lots of these examples where, you know, the surgical implant placement gets very close to the root. In this case, you can see an endo post-coron crown was needed because there was an apical lesion that developed after the fact. So we got to be very, very careful when we're placing our implants that will respect the adjacent anatomy. And again, with guided surgery and different concepts, we want to avoid this misalignment or these potential complications. We can use a guide pin, you can use a liniment burr, you can sequentially enlarge. This is one of my favorite burrs when doing implant surgeries. It's a very aggressive side cutting burr, so you can stretch your osteotomy, you can brush and again move your osteotomy and fine tune it to wherever you want. If the palatal bone or lingual bone is too hard, you can refine that and get your implant to a very, very precise position, you know, after your pilot osteotomy, and you don't want to end up with the implant position compromise. So again, we have lots of literature to support, you know, what happens if there is a violation. Another issue you can see on the 2.5 here, that there's an apical lesion with a short root canal. So we're going to put an implant in 2.6 with an indirect sinus. You know, where's this pathology, and will it infect our site when we go to put the implants in? You know, here there's another example of, again, a fistula coming out of this implant restoration in the lower anterior. What's the reason? Is there not enough buccal plate? Did we blow out the buccal plate? Is there a compromise in the position of the implant? You know, what exactly is going on to cause these types of problems? Here, very low incident, very, very low incident, but certainly can happen, is a mandibular fracture, which is not good at all. You know, we have a mandibular fracture here that's compromised the integrity of the mandible. So now there's a serious, serious problem. You know, what are we going to do to stabilize? Usually we'll refer to oral surgeon. They may put a titanium plate and screw tacks to lock that in to fix the problem. Very low incident, but we got to be mindful that it can happen. Less, you know, 0.3% is very low incident. So a patient with advanced residual ridge resorption pattern, or here, osteomyelitis and compromised healing, we got to be very careful on these surgical implant placements so that we don't compromise the mandibular fracture. Very low incident, but still it happens from time to time. So when we're doing our surgeries, we want to make sure we carefully evaluate the treatment plan. We want to have kind of a press fit go up and down slowly on our osteotomy. We want to have chilled saline to irrigate the site. We want to use guide pins when it's needed, use the liniment to refine, and just know the density of the bone we're dealing with and pay attention, you know, because we're only a few millimeters away from the inferior nerve or floor of the nose or adjacent roots or the lingual concavity and so on and so forth. So up to this point, you know, just we see some of these complications and try to address and confirm. So that's kind of part A, if you will, the presentation. And we're doing very, very good for timing. Part B, now I'm going to go by zones of the mouth. dealing with the posterior mandible, dealing with the anterior mandible, doing it posterior maxilla and anterior maxilla, because each anatomy presents their own, again, very unique challenges and concerns. So now I'm going to go by zones of the mouth to again address some of the surgical issues. Posterior mandible. We have usually D3, D4 bone, and one of the most obvious issues is dealing with the inferior alveolar nerve and location. Unfortunately, we also have studies that shows what are the incidents of altered sensation to the nerve. If there's studies, that means there's enough cases going on there. Lots of studies that talks about the inferior alveolar nerve, even some of the life-threatening hemorrhages that are case study that's out there. And again, also neurosensory disturbance. And Mish, and again, Randy Resnick wrote this very good article that talks about the mandibular nerve neurosensory impairment. And there's a checklist of getting 6 clinical testings that you should be evaluating when the patients come back on post-op and they say, oh, I'm still numb, or I have sensation that's different. You know, there are different testings we should document so we can monitor the success or healing rate. You know, we have 2-point discrimination, we have directional testing, we have sharp versus dull testing, we have cold testing. So there's different ways that we can kind of document, you know, what is the patient feeling today, and of course, hopefully, as time goes on and use of pharmacology with steroids, that sensation returns and comes back, return to full scenario. So paresthesia is obviously a serious consideration. And how do we manage it? We've been talking about it the whole night. A lot of planning up front, use of technology, cone beam, use of surgical guides, so that when we place our implant, there isn't that opportunity for us to violate the nerve when we know where it is and that we're not going to violate it. Here you can see that someone's put, you know, aside from peri-implant bone loss, that we got the implant into the nerve. Into the nerve also have its classification. You know, how deep is it causing? Is this a compressive injury? Compressive injury means you're going to take that implant out as soon as possible. And studies have shown if you cause a compressive injury, the sooner you take it out, the higher chance with time it will be reversible to normal sensation. However, if you transect and you sever the nerve, unfortunately, the incidence of return is very, very low now. And then, of course, if there's partial damage, now it's going to be a time-dependent recovery. It could be months and even up to a year before the sensation has some healing potential. The nerves heals very slowly. So it depends on what is the state of the damage and what caused it, and the degree of the damage. The healing or return of the sensation is very different. Here you can see there's a guide pin with two potential implants. Even on the PA, you can't really see or know where the nerve is. At the end, the implants go in, and we can kind of see, not very, very clearly, but some potential scenario with the inferior alveolar nerve. Now we take a pan. Now it's very, very clear that the distal implant, the apex, may be very, very close to the superior aspect of the inferior alveolar nerve. So is that, you know, really above it? Is it lingual to it? Is it buccal to it? Certainly on a 2-dimensional pan, it looks very, very close and very alarming. You know, the anterior implant looks like there's clear distance of maybe 3 to 5 millimeters away from the superior aspect of the nerve. But the back one looks very close, if not on top or into it. So it's a bit alarming. Where exactly is this apex of the implant? So with that in mind, you know, and I'm not going to be shy, this is my case. With that in mind, I just said, look, I'm not going to take a chance to guess where this implant is, and I don't want the patient to come back 2 weeks later to tell me they're numb. So while the surgery is there, like the patient is numb and I see this, if you have a cone beam, that would be the best to confirm. If you don't, here, this before the cone beams were readily available, immediately I back the implant out and you can see I'm using a shorter implant to make sure the apex doesn't compromise that area. In this particular case, the patient healed uneventfully. 2 weeks later, everything's fine. There was no paresthesia, but I'm not sure if I left the implant tip touching the top of the nerve, if that would still be the case. So if the worst case scenario, this was a compression injury, immediately take it out. I bathed the osteotomy with corticosteroids, dexamethasone, 6 milligrams per mil, would bathe it there for about 5 minutes, irrigate it out with saline, bathe it one more time with corticosteroids. And now in this case, without any grafting, I just put a shorter implant in, and whatever the osteotomy in that area, the blood will fill in, and the patient would heal like a socket, like any other extraction, without any issues. So here at the time of surgery, post-operative PA, right away, I noticed that, I'm a bit concerned of the length of the implant. So, we end up taking it out right away. And in this particular case was not a problem. So careful assessment is very, very important. So this is that risk factors dealing with infraalveolar nerve damages, generalized risk, the intraoperative, surgical risk, and post-operative risk. Incidence is still pretty low, but certainly we don't want to have this problem, and there's different timing of things. So this is kind of the table that talks about the differences of neurosensory damage. So don't think paresthesia is the only and one thing you can damage the nerve. Depending on the myelin sheath and nerve damage, you can have dysesthesia, you can have allodynia, you have different things that can actually cause the patient a lot of discomfort. So paresthesia is one of the things we're used to, but just know that there are other definitions and nerve damages that can be done. And again, depending on the protocol, this is out of the Mish's textbook and talks about a treatment and the algorithm of the steroids and modification. This is one of those things that I hope none of us will ever need or have to request it. But in case one of your patient cases have neurosensory damage, this is kind of the protocol we want to evaluate. Unfortunately, is it the drill that did the damage? Is it the length of the implant? And these are all the considerations we have to pay attention to. This is the testing that I was talking about. There's different tests you can use to determine the patient's status and the state of the nerve damage. And again, over time, how are we going to address this? So these are just kind of repeated slides, so I'm just going to skip ahead. But again, that reference I want to give with Carl Misch and Randy Resnick, that article is very, very helpful. You guys can look that up or contact me and I'll provide that article. It's a very good read and successful to avoid these problems. Second problem with the mandible, posterior mandible, is a lingual concavity. If you perforate that, you're very close to the soft tissue with the lingual artery and supply from the facial artery. So if you hit that, you can get very serious, profound, profuse bleeding. This is where you can potentially have hemorrhage that can compromise the patient's, success or livelihood, because they can bleed to death. And of course, there's also a lingual nerve. So when you're dealing with the posterior mandible, just note the mandible has this lingual concavity. Every site, every patient, due to anatomical differences, will have different variations of this lingual concavity. And certainly there are lots of patients walking around with the apex of the implant through the lingual. And if it's slightly through the lingual, it's probably not a big deal. The patient may not know about it or feel it, but certainly if you violate further, you can hit the lingual artery. And our kind of zones of safety is above the mylohyoid ridge and above the submandibular fossa. And you can see here on this depiction that you can see on a cross-sectional slice on the soft tissue where we can see the lingual artery, lingual nerve, the submandibular gland, the facial artery. So we have to know our limitations, that we got to stay above the mylohyoid ridge. We want to stay within the confines of the bone, and that we have to make sure that the steep undercut is not an issue, because you can easily, you can see here, get too long of an implant and perforate through the lingual and now cause a facial artery injury. Again, the patient may have a serious bleed to death potentially. Also, lingual nerve is also going through that area. So we got to be paying attention to staying, protecting the soft tissues where the lingual artery and nerve will innervate through and stay within the bone. Some articles are out there that talks about the lingual artery injury. So it's not that it's never happened, but it's very low incident. So when we're doing our surgeries, we got to stay within the safety zones of this lingual considerations. Inadequate volume of bone, it's not really a complication, but we see that all the time with some kind of residual ridge resorption. So we want to make sure that we would, graft accordingly. We can plasty the bone. We can do GBRs. Those are all potential issues. And we got to stay away from the mental foramen and whether or not there's a presence or absence of an anterior loop. So again, we can use cone beams to determine that, because the anterior loop may be an issue if you're placing borrower denture or locators with a residual ridge resorption that's moderate to advanced. That may be a consideration. We got to know if indeed there's an anterior loop. If so, how far does it extend anteriorly before it loops back, and all these considerations. So anatomically, again, we don't want to cause any neurosensory disturbance to those areas. So we've shown this, that there are these considerations. So the anterior loop is something we got to pay attention to on the mandibular arch that crosses over to the anterior zones. And we have, again, different studies that looks at the incidence of the anterior loop based on dissections and evaluations. And there's a big range between, 0.15 millimeters to literally 7 to 10 millimeters looping forward before it comes back. So we got to know our considerations. So the lingual concavity, the mental foramen, anterior loop, again, we have cone beams that help us to evaluate this. And same thing with inadequate volume of bone, vertical heights. So we can all address that using cone beams and proper surgical planning. We'll jump to anterior maxilla. Anterior maxilla, it's a very highly demanding aesthetic zones. We can all appreciate that. The buccal plate is very, very thin. And again, we have a quick residual ridge resorption pattern. There's also the incisive foramen as our palatal limiting factor. So we don't want to violate the lingual, the incisive canal. So anytime you're putting implants in the 1121 site, you want to make sure you know where that incisive foramen is, and you potentially need to graft to the buccal. The angulation of the implants in the premaxilla is very, very important. The depth of the implant is very important. So you got to know what you're doing so that it facilitates the emergence profile through the soft tissue and develop the aesthetics. This just happens to be my master thesis. So from 2006 to 2010, I literally read every article, every textbook, every kind of bit of information that we have on this topic. So on these anterior cases, we got to be very, very precise on our implant positioning and angulation and depth. And the soft tissue, obviously, for papilla regeneration. This, again, is a separate topic all on its own that we have to address. What I want to highlight is this. If you put the implant too shallow in the anterior zones, you got to pay a price. You put it too deep, you're going to pay a price. You put it too buccal, for sure there's going to be a price to pay, and also too palatal. So really, when we're dealing with these cases, this two palatal causing a ridge lap. So when we're dealing with these cases in the premaxillary zone, there isn't that much room for error. You got to be very, very accurate in three-dimensional implant placement positions. Again, this could be facilitated with a diagnostic wax setup, surgical guide, or guided surgery. So in the anterior zones is not that forgiving, and you got to be very accurate and precise and know what you're doing. That, again, unfortunately, I've developed a 25-point checklist dealing with any sites in the premaxillary zones that needs to be addressed. Let's go to the anterior mandible. The problem with the anterior mandible is the quality and density of the bone, which is easily D1, D2. And we have incidents where we can overheat and overcompress the bone. So we have to prepare our osteotomy with a lot of cool saline, very sharp drills. We have to potentially tap the bone, and we have to potentially place the implant and do reverse torque so that we a quarter turn back. Once we seated the implant, we'll release about a quarter so that the bone is not overcompressed. And so there's innovation of blood coming back to heal the site, and that we don't cause overheating or overcompression. So again, new drills, cool saline, pumping action, tap the bone, reverse torque the implant. Once you seat it right down, just give it a little quarter turn so that again, it will have innovation of blood supply. Here in the anterior mandible, sometimes we would consider immediate early loading, again, just because of the pure fact that it's D1 and D2 bone. Because we have a resorption pattern of the area, the lingual concavity now comes into play again. So we have this lingual resorption pattern where, again, you can see the implants, and we're going to end up putting it into the bone area that unfortunately the bone has resorbed inferiorly, superiorly, and then buccolingually, and forces us to have a more contour in the lingual, or having our implants more to the lingual. So we got to pay attention. Again, all this discussion of having these implants tip, violating the lingual plate is a concern. We have these concerns that we got to make sure that we need to know that where we putting these implant positions. There is that lingual blood supply that we want to stay away from, and we want to avoid these undercuts, which is a serious problem. And again, we want to, you can see that there's a post-op cone beam that 4 of these implant tips all have violated the lingual plate. So this is not a good outcome. Patients have a sensation and disturbance in that area. So we got to pay attention. Two-dimensionally, a PA or pan will not give us whether or not, a very accurate indication whether or not this there's lingual undercuts that could be a potential problem. Same thing if you're putting implants in the anterior mandible, we got to be concerned about the presence or absence of a mental foramen and anterior loop. Final zones is the posterior maxilla. Posterior maxilla, problem number 1 is the density of bone is usually D3, D4. So we got to decide if we're going to graft with a lateral window here, such as I'm in this case, or indirect. Biomechanically, we have a disadvantage. So we got to use the number of implants, diameter, and shape and size to facilitate so that the patient can bite, chew, and load this area and have long-term success rates. As you can see, the earlier study shows that most complications can occur with maxillary implants. And again, it's all due to the bone density issue. So we got to manage and decide what to do with a D4 bone. Is that, are we going to graft it? Are we going to do stage loading? Are we going to augment height and or buccal concerns? Are we going to biomechanically have enough implants? So we got to decide what to do with the bone density and quality and consider. Sometimes we'll consider a bone condensing using osteotomes, versa burrs, And there's different ways for us to densify the bone, if you will, now with the different techniques. So using expansion technique or versa burrs or osteotomes, we can change the bone from D4 to perhaps D3. We can do progressive loading with the provisional to strengthen the bone. That's how we would change the density of the bone. And then the volume of bone is grafting, whether or not it's an indirect lift or lateral window or GBR. Another complication in general in any surgical site is this kind of consideration where there's early flap opening in the site. So the issue is, was the patient a smoker? Does the patient have compromised healing? Was there a provisional that overloaded and compressed this? Did the patient, were they compliant with the area? So these are all potential problems that causes these things to open up and cause concerns. So early flap opening can be due to various etiological factors, and we want to do our best to manage and prevent these concerns. Big grafts can have, again, early suture opening. So did we get a release of the flap without tension? Did we suture properly? And all these considerations needs to be addressed. So in a very short period of time, in an hour, I kind of gave you guys a very quick overview of what are the surgical complications that can occur in implant dentistry. And we're all on a learning curve. It doesn't matter if it's your first implant, your 10th implant, your 100th implant, your 1,000 implants you've done. We unfortunately have to know that complications can arise, and we're all on a learning curve. We're all continuing to grow and learn. More science is coming out, more technology to help us and increase our success and survival rates. So we're all on a learning curve. It's just, where are you in your curve of learning? So if you're on a learning curve, like we all are, I'm 30 years doing this type of dentistry now. I'm still learning every day to see what else I can do to improve our success and survival rates. So if you're on your learning curve, certainly these types of study cups are very, very helpful to have a network of people you guys can talk and discuss and learn from each other. I think that's a great way to share our experiences. We let our ego, we let our pride out, we leave it at the door, and we just want to be open and help each other out to be successful and to be, serving our patients well. Dr. Yonglu already said we have a training institute that would again do these types of courses. And of course, if I can help in any way, shape, or form, you can reach out with emails, probably the easiest way. And you just, show some x-rays and cases in a geographic distance. I'll do my best to give you some inputs as to how to manage some of these complications. I think we all know implants are very, very successful. Lots of our patients have gained quality of life. And so the survival and success rates are very high. So although from time to time we have complications or failures, be mindful not to give up. The benefit outweighs the compromises and risks. Having said that, we still want to be very careful and diligent so that we run into less issues and complications. And success is within our own hands, and we can make and drive and decide, what kind of practice we have, what kind of patients we work on, and what kind of treatment we want to render for our patients. So with that in mind, again, I want to thank everybody for your kind attention. Here in Toronto is Friday night at 9 p.m., 10 p.m. And I appreciate everyone sitting in. For those who are watching this as a recording, I appreciate you also dedicating time in the future to review this webinar. This is my contact information. I have one and only email. I have only one cell number, and that's the office number. And again, I'm very honored and appreciate this opportunity to present to the membership. If you have any questions, concerns, and these slides, again, I want to make sure they're available to you guys in some of the articles, some of the checklists. So I'll forward this to your president and association, so all the members can get access to this and review it at a later time. Do we want to do a question and answer period?
Yeah, thank you
yes,
so much.
yes.
Thank you so much, Dr. Wen. Hey,
Sure.
anybody has questions, can get started.
我想啊，我们首先非常感谢林教授给我们这样一个非常精彩、全面的这个对于这个手术 complication 的一个讲解啊。我想啊，在我们当中，你做这个 implant 时间越长，你就会越感觉到啊，刚才林教授林医生给我们所讲解的这些呢是何等的有价值啊。我想我们下面就有一段时间哈。open 给 everybody，OK， 大家有什么问题，这个时候可以来问一下啊。
林教授，我想我有2个问题想问一下，好吗？
好，请讲。
好。你讲那个 premaxilla， 我觉得 premaxilla very challenging, too long or too short, we got to pay the price, which is true. I experienced it. And also, 我想问问你，就 from your experience point of view as a prosthodontist, now you think, see, for example, number 7, 8, 9 missing, right? Right now, the bone, it's okay. So do you prefer to do 2 implants like a 7 and 9, do the bridge, or you prefer patient only can afford a 2 implant space, or we do 8 and 9 and then anchor number 7? So like a kind of a cantilever. But ideally, we should not. I mean, I try not to cantilever. But number 7, since chili very little. So
Okay.
I was thinking, yeah. How do you think about it?
So that's a good question. The answer to that question is dependent on a few things. Number 1, of course, aesthetics. Number 2, depends on the available bone. Number 7, 8, 9. So that's a lateral, 2 centrals. So, and of course, it's not only the anatomy, it's the occlusion, the envelope of function in that lower anterior mandible and the position. If there's one site exception where we would consider a cantilever, especially a distal one, is perhaps this scenario where it's on a lateral with 2 implants and they should be splinted together. To me, that's a compromise. Ideally, is what you initially said, 1 implant in the 7, 1 implant in the 9 position. If there isn't bone, we graft the bone. We all know how to grow the bone horizontally. Ideally, that's an implant bridge. Biomechanically, it's a space distribution is easier. And aesthetically, when you have a pontic, all labs will agree the pontic soft tissue development, the emergence, is easier to control. When you have 8 and 9 together right next to each other, the bone and the papilla has a high chance there's some kind of resorption rate. So for aesthetic reasons, the pontic will look great, but the central 8 and 9, the bone in between and the soft tissue may be an issue. So based on what you just described, for sure, the first option would be a 7, 9 and graft that's needed. And for aesthetics and biomechanics, that's favorable. There are times in cases, the lateral, the 7 may be so deficient, you need to do a block graft, or the surgeon or the patient, medical status may not heal well from an invasive surgery. In those cases, maybe, we'll put it in 8 and 9 and offset and accept a distal cantilever. Having said that, when the restoration is done, you got to be very careful on the MIP position, on protrusive guidance and lateral excursive movements, that you got to make sure that the cantilever, distal cantilever, cannot take the force. So now occlusion and aesthetics and the biomechanics all have to put into play. But based on what you described, I would think a 7 and 9 would be optimal. And, placing 2 implants, 8 and 9, and then distal cantilever to the 7, is only an exception case.
I see. Thank you. Thank you.
Good question.
Thank you. Now, second question. Well, you did mention it. For the mandible, I mean, actually, for premaxilla, you prefer prefer 3 millimeter buccal plate, right? Then lower. I mean, for the mandible, I guess it's not critical, right? Because the bone it's more dense. It's a D1 bone, D2 bone.
So lower anterior mandible is back to the original 2 millimeters, exactly what you said. As harder quality of bone, so the density there. And the other thing is, again, dealing with biomechanics. We have a premaxilla that have a certain tilt to it, right? Between 12 to 20 degrees, depending on the overjet overbite. And when the patient bites down, there's going to be loading and occlusal loading. And on the buccal plate, if you don't have the 3 millimeters, that can resorb and take the load. The mandible is very different because of what you said. There's already D1, D2 bone. So the strict criteria of 3 millimeters not needed. 2 is very, very acceptable. We used to think 2 is universal around the whole mouth to the buccal. But Joseph Kahn and others have, what they did in the research was that they looked at premaxillary implants that were restored and done with loading post 6 months. So 6, 7, 8, 9 years down the road. And they did a cone beam on sagittal look at how little or how much bone throughout the whole implant. And they look at the soft tissues. Was there papilla recessions? Was there dehiscence or fenestration or failure or complications with these types of cases? And they came out with that study that say, if you have 3 millimeters of good quality density bone from the crest all the way through the length of the implant, in addition, good soft tissue biotype, meaning attached mucosa, non-movable mucosa, that gives the highest survival or success rate. Anything that's compromised in soft tissue biotype or thinness or the lack of thickness, you potentially run into some problems. That's kind of the outcome of that research. So that's the rule we've tried to go by now.
See. Thank you so much. Thank you very much, Dr. Lin. We learned a lot. Thank you. A great presentation. Thank you.
Thank you. So again, not to worry, I want to make sure these slides and some of the supplemental articles, the pre-surgical checklist and references I'm going to provide to the group, because I realize sometimes we all need to kind of sit back and kind of review this again, and I want to make sure that's the information is provided accordingly. I think there are a few more questions.
I have a question, Dr. Lin.
Sure.
This patient has a sickle cell disease and is going to have a bone marrow transfer maybe a year later. So he needs implant, and when we open the bone and found like he has a thin upper arch posterior, thin cortical bone, and then once you get inside, it's all empty inside. There's no bones, right? What do you do in this case? It's like you can place Explorer or turn around like all in one 360 degrees and no resistance.
So there are kind of two risk factors. One is, again, the sickle cell concerns, whether or not the patient have its ability to regenerate and heal appropriately post-surgery, anywhere in the body, even a regular extraction. So that you have to consult with the medical specialist that's handling this case. And whenever I come across these weird, kind of strange medical concerns, I get on the phone or I shoot them an email and explain to them what is it that we want to do, what antibiotics, what painkillers, what local anesthetic, what exactly we're trying to regenerate. Surprisingly, the medical field and the doctors and specialists don't know what we're doing. They just really don't have an idea. So I briefly explained to them, you know, it's like orthopedics, but in the mouth, where we're dealing with hard and soft tissues and stuff like that. And we need their medical clearance to support that the patient is in ASA2, meaning they're medically stable enough to tolerate these procedures. And if supplemental antibiotics and care needs to be addressed. So I want to make sure there's a medical clearance on some of these very, strange cases. Yours is a blood disorder, but there are other scenarios with bone and healing response, kidneys, metabolic diseases. We want to make sure that we want to rule that out as a general blanket. When you and I are not really sure, and we don't have a lot of literature to support this, I want to consult with the medical clearance and get a clearance. The second problem you're alluding to is, again, a localized issue, which is lack of bone volume and quality of bone. So in those cases, unfortunately, if we want to regain the volume of bone, at least to get an implant, to get initial fixation, we need to consider grafting. Is it a guided bone regeneration? Is it in conjunction to sinus grafting? Do we mix it with PRGF? What kind of membrane do we use? Resorbable, non-resorbable? And first and foremost, we got to get that volume of bone available. Then we got to put the implant in and lock it in. Now, in these cases, the way you're describing, 100% you need a prolonged healing period. Something that's 4 to 6 months on a healthy individual, we're ready to start the restoration. Anytime these patients are compromised, you right off tell them you need to let the implant heal undisturbed minimally 9 months up to 12 months. So that's number one factor. Number two, when we go to uncover, before we make an impression, we want to do an ISQ, implant stability quotient. We want to make sure to the implant integrated to the grafted bone has indeed healed. We want an ISQ reading of greater than 60. So at the Grad Prosto and U of T, we don't let any of our pros residents start the prosthetic phase until we get a good reading of greater than 60. Third, in the way you're describing this posterior maxilla, we would do what we call progressive loading. That means we make the impressions, splint the implants. We will ask the lab to get a screw retained provisional, but we keep it short to the occlusion. So it's about 1 millimeter or 2 away from the occlusion. And we have the patient slowly go on a soft diet. It's quote unquote, if you will, physiotherapy of the jaw. So slowly, progressively load the implant a month, 2, 3, and then again, we will confirm and evaluate the bone has strengthened over time, and then finally put into occlusion. Again, add material, composite or what have you to your provisional. And again, let the patient slowly load and strengthen the bone, and out 4 months, 5 months on the provisional. Then we go to final biomaterials of choice. And again, paying a lot of attention to occlusion, oral hygiene, the access and design. So these are very, challenging cases that we got to pay attention, because the medical compromises, the local region is also an issue. And of course, you got to remember, implants an elective procedure. Sometimes if there's too many risks and compromises, we might just consider, unfortunately, no treatment or partial, and again, have that available to the patients, because you don't want to start the surgical intervention with a lot of grafting, a lot of implants, a lot of costs, a lot of invasive procedure, and have failures or complications very early on. So we got to be very careful in making these decisions, and we'll call risk factors assess accordingly.
Okay. Okay, thank you, Dr. Lee.
Yeah, good luck. That case sounds pretty challenging, so be careful.
好，我们在那个chat room 里头有3个问题哈，林医生，第一个问题是 What do you think about the zygoma implant?
Okay, I personally have not learned to do zygomatic implants. I personally have not placed them, but I have restored them. I think those are very extreme cases. I don't think GPs and even me as a specialist prosthodontist will see enough cases to make us very good and proficient at doing zygomatic implants.
Mm-hmm.
I do see these patients, I refer to an oral surgeon. Now we need to have an oral surgeon who does enough of these cases to be able to handle the surgical intervention. There are some anatomical risks that are very different. Prosthetically is very different. Having said that, it's either that or it's a hip graft. Either that or it's got to be a complete denture. The patient's got to tolerate. Unfortunately, when the patient has that severe atrophy recession, everything is a compromise. I'm not an expert at zygomatic implants. I know they exist. I know they work, but I also know the zygomatic implants have blinded some patients. I also know zygomatic implants can have fractures and breakages, and they also fail. When they fail, you can imagine an anatomy. It's a long implant and it's a serious consideration. So my point is, if you want to consider zygomatic implants, you got to rule out everything else. Would you consider just a denture? Would you consider just, anterior grafting and tolerating an overdenture and calling it a day? Would you consider hip graft? Would you consider a zygomatic implant? If you do, you need to work with a surgeon. And again, biomechanics is going to be at play when the final provisional or final teeth go in. You got to pay a lot of attention to occlusion and maintenance issues. They are not without their problems. And unfortunately, when there is a problem, it's a pretty serious problem. And unfortunately, I've had to deal with that at the faculty with implant fracture and had the head fracture. And now, of course, implant failures too. So they do work, but you got to really proceed with caution and be very careful.
Mm-hmm. 另一个问题 ，What do you think about the immediate implant?
So immediate implants, I actually do a lot.
Mm-hmm.
Immediate implants, let's define, is the day you extract the tooth, is the day you put the implant in. So if you want to do immediates, number one, you have to have available bone. So apical to the socket, you have to have at least 3 millimeters. Usually lingual or palatal bone, there's enough to evaluate to lock the implant in. So that means you need to have a cone beam. So we do teach an advanced course in implantology dealing with immediate anterior posterior implants and immediate anterior provisionalization and loading. So again, a cone beam is mandatory. You got to know how to extract the tooth atraumatically, and you got to put the implant in into vital bone that can lock the implant and get primary stability. So my office, to be quite honest, we've been doing it for a long, long time, but it's anatomy and case dependent. It's not something that you want to do it, I want to do it, patient wants to do it, but immediate implants is anatomy dependent. And of course, there's some surgical risks associated, higher risks associated, but we have enough documentation in the literature, it can work very well. And the aesthetic zone can hold the soft tissue and profile and bone, but it's case dependent. There are times you must stage it, which means you extract, you clean out the socket, you roll the bone in the socket, you let it heal, and you come back at a later time. But if the anatomy or the cone beam allows for immediate, certainly there are benefits. It's shorter time, in 4 to 5 months, everything's done. Staging it, you're looking at, 4 months of socket healing, 4 months of implant healing, a month or two to get the implant in, you're looking at 10 months versus immediates in 4 to 5 months, you're done. And of course, less surgical intervention with the patients, less appointments is all going to be a benefit. So, we do it, and I think it's very, very successful, but just be mindful, again, knowing the anatomy first.
Mm-hmm. Next question. Hello, Dr. Lin. Can you tell us about your opinion about the pancreas? Does it worth to buy? I think this ISQ is another machine to reading the implant stability, right?
Yeah.
Pancreas.
So the first generation is called the Austell unit. And the Austell unit uses a peg you screw into the diameter and length of the diameter, the type of the implant, and uses magnetic frequency to bounce back almost like a sonar to see if there's lateral movement to the implant to the bone. So that's called the Austell unit. Later on, the same scientists and the people moved off and started a different company using something called a Penguin. So the pegs are different. Their first generation was Austell are using titanium smart pegs that they don't want you to sterilize and use, and you got to keep buying it for new patients and new cases. The Penguin, they're using a different material that you can sterilize and reuse, so you don't have to keep buying. And there's different philosophies on why you have different smart pegs. The cost-wise, I know Penguin costs less because they're in competition a bit later in the market. And actually, I have both of them, and they work equally well. They both work equally well. But if you don't have one, in terms of implantability quotient, you don't have one of these units. Penguin is very cost-effective. You don't have to you can re-sterilize the pegs, so you don't have to keep buying, and they work just as well. But to be honest, right now, you could probably call the corporates and have them compare the two. Those are the only two in the market, either through Austell, which they again have different variations, and they have cloud versions where, you know, when you do the reading, it goes on the cloud to document your patient, which site, what readings, and they have different, you know, bells and whistles. The Penguin is cheaper. You don't have to sterilize the pegs. It gives you the reading. You just write it on your chart. You don't have to have all this high-end technology stuff. But compare the two, but the cost-wise, as far as I know, Penguin is a bit more economical than Austell units.
That's good. Next question.
Okay.
What to do when patient bites cheek after crown is delivered?
So when a patient bites their cheeks, that means the crowns or the occlusion has violated that neutral zone. Remember, in denture therapy, we have a neutral zone. So when we smile, the muscles between the buccinators and the tongue drapes the buccal mucosa. So when you bite your cheek, that means your outside of your crown probably went too far out. And more importantly, when the patients bite down, there isn't a horizontal overlap. So I don't know if I can show you. There isn't that horizontal overlap to let the soft tissue drape on the buccal mucosa. So if it's tight end to end, or this is the lower, this is the top, if your occlusion is so tight and you don't flare out this the incisal edge of the buccal or tip the inside in, if you don't have this horizontal overlap, is when you cause cheek biting. So you gotta have to adjust in the mouth and evaluate, did you bring the buccal contour of your upper too far out, and or did you create this enough horizontal overlap? So you know, when we have natural teeth, we have this natural upper arch where there's the buccal aspect of the upper and the lower have this overlap. So when you fabricate this, or the lab fabricates this, you need to recreate this so that the tissues will drape over. When the patients bite down, the cheek doesn't slide in there, which is now prosthetic concern.
Another question is, what might be your opinion on short implants? For example, 6 millimeter or less, in terms of the indication and the complication.
So short implants have its own niche or own place. So for example, you have advanced vertical ridge resorption. You know, how predictable is it to grow bone vertically above the nerve? It can be done, but it's very, very risky and low success rate. So if you want to learn that, you can go to Budapest. You know, Esteban Urban is known for that. So in lieu of trying to grow the bone vertically, you can use short implants. So they can be as short as 5 millimeters, 6, 7, 8, anything less than 8. That's short implants. They do work, but there are some criteria. Number one, when I use these ultra short implants, I would always two-stage it. even if I get primary stability, I don't want to put a healing abutment to cause micro movement and challenge. So I always two-stage, put the short implants in, cover screw, and suture it up, and let it heal undisturbed. Second, the healing time I would allow longer, because again, the bone to contact implant ratio is less now. With a shorter implant, you have less bone to contact ratio. So you want that to have more time to integrate with whatever surface area you have. So I would wait longer. Something you would wait 4 to 6 months on a regular length. Here, I would wait 6 to 9 or 9 to 12 months and do not rush the nature. The third thing I would do is what we just said before. I would always test the osseointegration with, again, an Ostel unit to make sure that it is really integrated. And fourth and final is, again, that progressive loading. I would consider putting a screw retain temp in wherever it's in the mouth, single or multiple units, and again, strengthen the bone, have the patient bite on it. And once you put an occlusal load and biomechanically load, the bone will turn over to be mineralized lamellar bone instead of woven bone. So it's like physiotherapy. If I broke my arm and I have a cast here, and I put a cast on, they will say, don't use this arm and immobilize it for 4 to 6 weeks. Once they remove this cast, there's disuse atrophy to my bone density and volume and muscle. What are you gonna do? What the physiotherapy is gonna say, use 2 pounds, use 3 pounds, like slowly bring it up to physiologic loading before you just pick something up that's 20 pounds, because you can induce another fracture. So this is a similar concept that we need to go through physiotherapy or biomechanical loading, especially on short implants, so that the loading is going to be ideal. And the final biomechanical or prosthetic consideration is that you want to make sure on shorter implants, the loading is vertical, that the axial loading of your occlusion is narrow. So the occlusal table of your crown should be just enough to promote axial loading and chewing. And there should be not that much what we call incline loading or excursive movement loading, because again, that can cause potentially crestal bone loss. And if you're using a 6 millimeter implant, you lose 2 or 3 millimeters. That's sometimes a normal remodeling scenario. The implant's almost going to come out. So that is why I say always stage it in terms of having the implant heal undisturbed, so that there's little to no chance of bone remodeling, and then progressively loading. So short implants do work, but based on the literature and my experience, it's a very strict protocol on what you got to do if you guys choose to use a shorter implant. You cannot treat it as a regular length implant. It's very different.
Okay, next question. What is the ideal depth of the maxillary anterior implant? 1 to 2 millimeter below the bone? What is the complication of too deep?
The way you describe it, if the hard and soft tissue on either side is healthy, wherever the crest is about 1 millimeter and 2 subcrestal is ideally the depth of the implant placement, for a few reasons. Number one, the lap needs the interocclusal restorative space to get emergence profile. Number two, we have literature to show if you open the flap and expose the buccal plate being so thin, when you reposition because you disturb the innervation, the buccal plate, because it's so fragile and thin, can remodel up to 1 millimeter. So if you put the implant at the bone, and if that buccal plate resorbs 1 millimeter, now you're looking at the titanium threads or the connection. So most of us will put about 2 millimeters subcrestal. That's not considered too deep. But if you go deeper than that, which again, in some cases we need it because of the vertical bone loss, now we have an issue of either cement trap, which again will deter from placing it that deep and go screw retain, And of course, the crown to root ratio, aesthetically, there will be some pink porcelain emerging through the soft tissues. I can tell you this much. If you ask a lab tech, you want the implant deeper or you want it shallow or at the bone, which one would you consider? 100% the lab tech would say, I prefer slightly deeper than to be shallow and above the bone. So we don't put it in above the bone, we don't put it at the bone. Kind of what you just said, about 2 millimeters subcrestal is the position we would be targeting.
Okay, next question. What is your opinion about the ceramic implant versus titanium implants? The zirconia implants.
I don't have any experience in doing the zirconia implants. I don't do them. I know they're on the market. My question is simple. Why zirconia? If someone says they are concerned about metal, they got to know zirconium is a metal. It's a white metal. It's on the periodic table. So when someone says, I want to be non-metallic, that just doesn't make sense. Someone says, oh, it's white instead of titanium. So what? The titanium implant's in the bone. The bone and the soft tissue is not transparent. It doesn't show through. So when somebody tells me they want to use a zirconium implant, I really don't know what the reasons are. And the success and survival rates is not enough literature. And the zirconia implants right now, some on the market is one piece. That means the abutment and the crown needs to be cemented. That means when you put the implant in, that abutment position is predetermined. I don't like that. That's not a good solution. We learned from that. We want a two-piece. So only recently there are people coming up with two-piece zirconium implants that screw retain. But I gotta say, why am I doing it like this? What's the purpose? Why am I using zirconia when we know titanium has such a high success rate? So I'm not now convinced there's a rationale or purpose in zirconia implants. So I'm not jumping on the bandwagon. I've been around 30 years doing implants. I've seen lots of things come and go. And, when they started, it sounded like a great idea. At the end, it was a bad idea. Our patients suffer through trauma and issues, and we got to redo the dentistry. And at the end, they just vanish off the marketplace. Right now, I don't want to jump in until I see real clinical benefits. I want to see some data of at least 5 years that shows the survival success rate. Then if and only if I have the science to back it up and I see clinical benefits, I'm going to jump in. Right now, someone that tells me it's metal free, that's not true. Somebody says it's white. Well, none of my implants should be shown through the hard and soft tissue. So I don't need a white implant. And white is not, it's not any, to me, it's not any better than titanium. So I don't see the need and rationale right now. So I'm not doing them until later. Until there's a
the last, I think that's the last two questions. Okay, for two questions. Okay, we have lots of the thin biotype patients. How do you persuade the patient to go through these invasive bone graft procedures, such as vertical augmentation or Ramus jaw donor site?
Okay, so those sounds like it's two separate questions. One is thin biotype. So I have a periodontist in-house. So biotype, ideally in a perfect world, we want 3 to 5 millimeters of attached mucosa next to our implant. Lots of our patients, unfortunately, walk around without that. And what the problem is, it's movable mucosa. It can trap bacteria. It's sometimes irritating to the soft tissues. So when I speak with my periodontists, they would suggest, if possible, the soft tissue grafting goes first. A connective tissue graft for free gingival graft goes first to augment the soft tissues. Then and only then we would consider bone grafting, because that makes sense. We have good tissue to suture against. We have stable mucosa. And then finally at the implants can go in and the restoration can go in. So that's the perfect scenario, is pre-grafting, pre-implant placement with a soft tissue graft. Second, timing is in conjunction to your implant soft tissue graft procedure. But now you're asking the body to do a lot, to heal from the osteotomy, to heal from your potentially GBR, and to have soft tissue healing. So the patient better be very compliant, non-smoker. They got to know how to maintain it, and the surgery is a little bit trickier. So you got to be very careful. You're asking for a lot of miracles to happen all at once. The third timing, which sometimes happen, post-implant placement crown insertion. Now the patient presents because every time I eat, food gets in there, it's irritating, it's red and stuff, and then we can consider a connective tissue graft from a periodontist if and when it's needed. So we got to assess everything. Will the patient tolerate that grafting procedure prior to implant placement? Or we just tell the patient, look, this is what you can do. There's some risks and concerns if you do it or don't do it, and let the patient decide. Your second question is very different, which is harvesting bone from the ramus or even the symphysis. It's very similar to taking out wisdom teeth. The healing and the response is very similar. So harvesting autogenous bone from the ramus and the symphysis is very, very beneficial. We all know with bone grafting, that's a gold standard. We're bringing osteogenic bone that can regenerate, and patient would appreciate it, recognizes its own bone. So whenever we can have a source of autogenous bone, that would be beneficial. Again, the patient's got to decide. If they don't want a secondary donor site, then we'll use a bottle bone, allograft, xenograft. But it's the way we present to the patients. If we tell them, look, you took out your wisdom teeth, this will heal like that, and there's a significant benefit in having autogenous bone, and we got to present it, and you got to be confident and know how to produce that. But clinically and scientifically, we know autogenous bone is the gold standard when we need it.
Okay, next question. For the implant length, is it true that the longer the better? If the bone is enough for the 12 millimeter up premolar implant and it is 3 millimeter below the sinus floor, is it better to use the 12 millimeter or use the 10.5 millimeter implant? Okay.
So length is like this. Good question. Before we thought the longer the implant, the better. This is not really that true. If I have an implant, you gave an example of 6 millimeter. I have an implant that's 12 millimeters, so two different lengths. When both implants integrate 5 months, 6 months down the road, we put a crown on top of both implants, the prosthetic loading, the stress distribution, both a short implant 6 versus 12, all the loadings at the first 2 to 3 millimeters. Nothing happens to the apex of the implant. So you would think, why go longer? You can risk hitting some vital anatomy and graft and stuff. Well, the reverse is true. We already said peri-implant bone loss is multiple etiological factors, and we don't control it. None of us in the profession can promise the patient they will never get crystal bone loss. If you have a 6 millimeter implant, you lose 2 to 3 millimeters, that implant needs to come out. You've lost 50%. You put a 12 millimeter implant in, you lose 2 to 3 millimeters, while you got 9 or 10 millimeters. So the analogy I want to make is a patient with periodontal disease. The longer the root, the better the favor of crown to root ratio, the longer the tooth or teeth can last. The prognosis may be longer. So now this is a debate, if we go shorter, we can provide, be safe to not hit any vital anatomy. But yet, if we have a longer implant, assuming we potentially have some peri-implant bone loss, and hopefully doesn't, the longer implants for sure will have a longer survivability. We can trim the gums, we can treat the peri-implant bone loss, and the longer implant provides the strength. So what's my take-home message with length? If the anatomy allows very safely the length of an adequate implant, whether it be the nerve, the sinus floor, the nasal floor, whatever. If the anatomy allows for it, I would put the implant, the longer the implant, providing I stay away from vital anatomy. So if the anatomy from the crest to the nose of the floor is 15, I would put a 12 in. I wouldn't put a 10.5 because I can have a ideal scenario. And of course, the other consideration is immediate. We already asked. If you take out a root socket, you need to have a longer implant to go beyond the apex, at least 3 millimeters to lock the implant in. And another indication is immediate loading. In the anterior zones, if we do immediate loading on a screw retain provision on the implant, you again need that longer implant to lock it in. So, but if it's a healed site per se, and you're not doing immediate implant, immediate provisionalization, I would go with the maximal length of the implant, provided again, very, very clearly, we stay away from any vital structures. No lingual perforation and away 2 to 3 millimeters away from the inferior nerve. Don't engage the sinus floor if you don't plan to engage it. If you want to engage it, make sure you got to deal with it with an indirect augmentation or lateral window augmentation. You know, so it's one of those things. It's longer is better, yes, but it's not mandatory. Shorter have its also benefits, so we got to outweigh this. So that's why I started this webinar saying, train the brain. We have to look at all the factors and make the careful decisions.
Okay, here's the question, very interesting. Sometimes the anterior maxilla really does not have enough volume of bone to accept the implant. How do you feel about the nasal plantain nerve bundle removal and graft in the nasal plantain canal to recept the implant?
So the nasal canal, nasal incisive canal, Mish, Urban, and other people have talked about drilling the contents of the neurovascular bundle out and grafting into the site and putting implants in. I'm going to be honest, I read that and I've only done it twice. One time, no problem. Patients have no problem. Second patient, starting to develop sensation. So I look into the literature, but there is this reported literature. The neurovascular bundle here will anastomose, it will regenerate into the innervation. So if you hollow out that incisive canal, instead of doing a GBR to the buccal, some literature supports the nerve will grow back. And when it grows back, the patient is aware of it. It doesn't hurt them. It's just they're more aware of something being there that's uncomfortable. So I've only done 2 cases. I'm not an expert, but I don't think I want to do that because that's going against nature. You know, if we need to grow the bone buccally to 1121, we know how to do it. GBR, ridge split, block graft. When you drill out a neurovascular bundle or a canal, that is by nature not the way we're supposed to do it. I just don't think that's very successful. Anytime we do something, instead of restoring what nature designed it and we go against it, we're going to lose every time. So I don't suggest people trying that because it's very, you know, like, I mean, if the crown and implant is done, the patient comes back every 6 months that I feel something, it's not comfortable, it doesn't hurt, and now you have integrated bone. Now you got to take the whole thing out and start again. So I don't suggest people to take out the neurovascular bundle out of the incisive canal because we have literature to show, I'm not the only one, that there's re-innervation to the sensation and patient reports uncomfortable. So I don't want that in my practice. So I don't recommend that.
Okay, that's the question. Dr. Lin, how do you think about the mini implant?
I'm sorry, what's the question?
How do you think about the mini implants?
Huh.
The mini.
So mini implants is defined as anything less than 3 millimeters, you know, in terms of diameter. It may be one piece. Now they may even come in 2 pieces. There's again very strategic time and places to use them. You know, if you don't want to go through a lot of heavy grafting, the patient's medically compromised, and you do mini implants as a transitional or as an overdenture, you know, and and ring overdenture, probably it's okay. To use as a crown and bridge, which I've seen people extrapolate that, where they do full mouth of 6, 8, 10 mini implants, cement retained. Again, the concern right now is there isn't enough literature for that. And if one mini implant fractures, it's a bit of a concern. And you know, depending on the college, depending on the lawyers, they can give us a hard time. They can say these are not meant for definitive implants. Did you tell my client? Now you have something fractured in the jaw. Are you gonna go get it? Are you gonna leave it? So our college is very quiet on this issue, which is a concern because they're not taking a position. So it's one of those things, if everyone's happy, there's no complications, people don't care. But once there's something that happens, like the implant breaks, or there's failures, or there's peri-implant bone loss, people can challenge and say, where's your scientific literature that show that what you're doing is backed up by science? Who says putting 8 or 10 mini implants to bypass grafting with a cement retained protocol have long survival rates? And we don't have literature on that, very little literature. So anytime we're doing something without scientific backing us up, I'm concerned that one of us can get in trouble. You know, you can do 1,000 mini implants, all you need is one bad one, and now you gotta report to your lawyers, you gotta report to your college, which none of us wants to go down that avenue. And as soon as a lawyer or opposing expert says there's no science behind what you're doing, you're in trouble.
Okay, last question. Okay, what is your opinion about the splitting the implant together or individually crown for multiple consecutive implant restoration?
So now we're talking about splinting or not splinting the implants. So to me, it's pretty straightforward. In the back of the mouth, heavier bite force, less aesthetic demands, I would consider splinting the implants biomechanically because we need the implants helping each other out. There's no more periodontal ligament. There's no more sensory feedback to the brain of how hard we bite. Lots of our patients are having parafunctional habits. Some of them are compliant with night guards, some of them not. So in the back of the mouth with heavier bite force, aesthetic is not a big concern. I would splint them. In the anterior zones of the mouth, if we do have multiple, the bite force is 50 to 70 pounds versus 100 to 1,000 pounds in the back of the mouth. So the bite force in our jaw closure articulation is less bite force. Aesthetics is more of a concern, and hopefully patients will floss in the front and keep clean. So if I have multiple in the front, I would consider individualizing the implants again, because I know there's less biomechanical forces. Aesthetics is a little bit more important to have, you know, regular contour and separated crowns. And if they are compliant with oral hygiene, hopefully they can have access to that easier in the front of the mouth. But again, these are just general rules. It depends on their bilateral posterior support. Does the patient have parafunctional habits? How stable and healthy are the remaining adjacent teeth to hold the vertical and position? So those all needs to be addressed. So, you know, essentially biomechanical, aesthetics, and maintenance issues needs to be all contemplated before making a general statement.
OK， 好，非常感谢林医生、林教授给我们这个非常精彩和非常全面的这个一个讲座。我想因为时间的关系，我们就停到这里了哈。大家都有这个林医生的这个email 和电话联系方式，我们也荣幸的邀请林医生来加入我们这个Digital Dentist 的这个群哈。到时候有时间把林医生加进来，大家到时候我们在那里可以有一些互动，好不好？ 我们再次感谢哈，代表Ample 感谢林医生对我们的北美这个华人牙医的这个大力支持讲座，希望在今后呢我们有更多的合作。OK， 好，谢谢，
谢谢，
好，
谢谢，
好，
谢谢。
好，我最后呢还有几件事情跟大家提一下。第一件事情是我们这次林医生给我们的讲座呢，我们是由这个 JMU 这个我们中国的一家公司呢Dental 这个 supply 公司给我们提供的这些这个的资助 ，OK 的 support 那我们呢也在跟那个 JMU Dental 呢联系他们，他们有些产品也是蛮好的，大家也可以到他们的网站去看一看，选一些比较 popular 的，我们可以团购，或者是说您单独买的话，我们会要求他们给我们这个 Ample 这个会员有一些discount， 好不好？这是一件事情。大家，我们首先我不知道这个 GMU 于总来没来啊？您来吗？那个新梅于总到这今天要跟大家说。
他没有到了吗？于总没到，我邀请了他，他可能没有。
他没上来吗？那好，那行，那我们以后再跟他讲。OK， 再一个呢，就是说下个月。8月份在 IICD 在 San Antonio 就马上就开始了 ，OK， 大家还有没有报名的呢？大家尤其我们 Ample 会员呢，大家尽量争取都去报名。这也是我们第2次 Ample 的年会，在那里头来，尤其是礼拜5我们有个 Gala Dinner， 我们跟大家一起讲。那在这个会上呢，我们会有一些announce 我们 Ample 的一些项了，一些要求了，我们这些。我们以后这关于是怎么来发展 Ample 或者怎么发展 Ample 下面的 DSO， 我们都有一些想法，也是愿意听取大家的意见。OK， 这是第2件事情。那第3件事情我想今天我们大部分的我们的 Ample 的 board member 都在这那我们也会下个礼拜65点钟我们有个 board member 会，大家把时间。
是明天，张医生，不是下周，就是明天。
就明天对不起，明天就明天OK， 那好，我想我就这些了。那谁，新梅或者卢老师，那个陈医生，你们还有没有什么事情要讲的？大家这个机会大家都在。
我没有了，谢谢林医生。
谢谢。
我没有了，谢谢林医生。
OK， 陈医生有没有？薛医生，薛老师在吗？还没有。那好，那如果没有的话，我们就再次感谢林医生我们希望以后有更多的下次到南加州一定跟我打招呼我们来到这个
好，谢谢，
有机会 OK， 好，那我们今天就到这里，好不好？谢谢。